Okay, this is segment 1 for Friday's AP Psych classes, and we're going to finish up with therapies first and then get into social psych. So we left off talking about stress inoculation therapy, and the idea here is that this is a therapy that's used by cognitive behavioral therapists. So this is the first example. And the idea is that once the stress-causing situation is identified, the patient is taught to replace the bad thoughts with positive ones. And again, using the cognitive view that a lot of times people will describe the world and thus think of the world in a negative way to themselves, but cognitive therapists push very hard for the idea that you can convince the person to look at the world differently, and thus, in this case, the stress-causing situation will not seem quite as bad. So, this is to turn the patient's thoughts into a vaccine against stress-induced anxiety. So, think positively, and you will minimize your own stress. Now, the next example of cognitive behavioral therapy is something called rational emotive therapy, or RET, and the creator is a man by the name of Alfred Ellis. It's based on the idea that people's psychological stress is caused by irrational and self-defeating beliefs. The therapist's job is to challenge these beliefs. And so this is kind of an in-your-face type therapy, because the therapist will very quickly tell the person to stop having irrational thoughts and tell them to be rational. Realize that good and bad events are not global. In other words, just because one bad thing happens, it's not going to happen. Everything isn't bad. So, for instance, being rejected for a date does not mean you're not attractive to others. They tell people to avoid musts and shoulds and other absolutes. RET uses persuasion, challenges, and demands by the counselor to help the client see this perspective. The next one is Beck's cognitive therapy, and we've talked about Beck before. It's similar to RET, but not quite as forceful. Beck, another cognitive therapist, sees depression as caused by negative patterns of thought, which we've seen consistent in all these theories, and he believes they can be stopped with therapy, but the therapist is much less confrontational with the client than they are in rational emotive therapy. Okay, our next therapy is group therapy, and you've probably seen a recreation of this on TV or in movies. It is a group of people sitting in a room, usually in a circle with a therapist, or at least one therapist as part of the group. And the idea is that group therapy has one key component, and that is that the setting of the group situation itself allows both the therapist and the client to see how the client acts around others. Now, there's a great advantage to group therapy, and that is the group support. One of the things that people in group therapy find is they're not the only person who has feelings as they do, or feelings of difficulty or problems. Another thing that you'll find is that the group itself will help each client or each person to begin to understand through modeling some successful behaviors. In other words, somebody else in the group will say, hey, when I had that type of an issue, here's what I did. And another thing that's important here is that the client or the subject themselves will often feel more connected to what they're told, because the insight they get from the group is usually insight from people they consider to be peers, or at least people a little bit like themselves. And so what's stated as something that could be an option for them to change their behavior seems more believable than if it's given to them by a paid expert. Another advantage, of course, is a very basic one, and that is that it's cheaper per client. Now, an offshoot of that is family therapy. And this is taking issues to another setting that can change the perspective as a family that might have issues tries to deal with them. Oftentimes, in fact more often than not, in family therapy, the issues that are being dealt with are communication issues. And because of this, sometimes it's not as successful as people would like, because the problems are too entrenched. One of the key ingredients is that oftentimes you can get the family dynamic to change in the setting of the therapist office, or wherever the therapy may be held, But the difficulty is then taking it back to the original environment where the triggering cues are still there and making sure that it still continues to be successful. But definitely communication is part of that. The next example is an offshoot of that, of course, as well, and that's couples training. Two types you'll often see here are marital training or marital therapy and empathy training or empathy issues training. Empathy training is to help communication and express mutual expectations in a non-threatening setting between two people. The clients are taught to actually listen and understand their partner's concerns before they respond to them. And this is something that in many situations, because we all tend not to be as good at listening as we should be, it doesn't seem to happen. So this training is very important, because if each side in a dispute, especially one between people who at least at one time had some decent relationship with each other, will be better off if one person and the other one thinks that the other person is listening to them. Whatever form it takes, it works best with both partners rather than one. One of the biggest problems with marital or relationship therapy is oftentimes the one who is the person in the relationship who is the second into the therapy situation is very fearful and apprehensive, because they believe that the other person in the couple has already given away tons of secrets about them. And so it takes quite a while for them to get at ease with the therapist. But if that's possible, and if it happens, it can be very successful. So what about the overall success of therapy itself? A researcher back in 1952 by the name of Eisnick said that therapy is no more successful than leaving the people alone. Now, this is a very harsh view and definitely not true. Therapy is very good in dealing with moderate problems, and although it's not as successful with severe cases, it is better than no therapy at all. So generally, what can we say about all the different approaches that we've seen as far as talk therapy? Overall, the current approach is usually some hybrid of the ones we've talked about. The trend today is towards something that's called eclecticism, and it really is where people will pick and choose the ones they think as therapists work best for them, they're more acclimated to, and they may change their techniques as different patients come in showing different issues. Okay, now let's move on to drug therapy. And this is sort of the other side. Not a whole lot of talking going on here. This is more the medication, and as with each passing year, we get more and more insight into how the brain works and the neuroscience behind it. Drug therapy is modified. But one of the issues that is a big picture issue for this is the notion of a fear of what some people call the pill mentality. And that's the idea that because it's relatively cheap and it works very quickly, that there is a fear that some practicing psychologists, whether it's because of pressure they get to save money or pressure they get to make quick decisions, will just in essence drug the person and throw pills at them rather than truly trying to go after the issue that's causing the mental ailment or difficulty, whatever it might be. But in any case, whether the pill mentality is true or not, the first category we're going to look at are antipsychotic drugs. Now remember, psychosis is the loss of touch with reality. Antipsychotic drugs reduce psychotic symptoms such as hallucinations and delusions, and they do so by blocking dopamine receptors, as we said before. They usually work better with what are called positive symptoms such as hallucinations, but not as well with negative symptoms like social withdrawal. Some problems, of course, with these are the side effects. Sometimes they're side effects that are unexpected, and of course, like any drug therapy or any type of drug regimen, you have to worry about addiction. The other problem is that it doesn't always treat the underlying psychological problems that may have been the basis of the need for the drug in the first place. Our next category of drug therapy are antidepressants, and the types include, and this was really what there existed until the late 1980s, there were really two types. The first were called MAO inhibitors, and the second one were called second type were called tricyclics. Both of these work, but often had some side effects that were in some cases so extreme that the drugs themselves would not be used as often. But the key to both of these drugs is that they increase the concentrations of serotonin and norepinephrine in the brain, two of the compositions that are a big part of what creates or is the byproduct of depression. It was in 1988 that Prozac, a drug that began to be used at that point and continues to be very popular, appeared. Prozac reduces the uptake of serotonin in the nervous system. In other words, the normal process of getting rid of it is slowed, and so serotonin stays around in greater amounts, especially in the brain. Now, this group of drugs that reduces the uptake of serotonin in the nervous system and in the brain are known as SSRIs. Paxil, Zoloft, and Effexor, which you perhaps have heard of, are second-generation SSRIs. Effexor also raises the level of norepinephrine in the brain, thus it is known as an SNRI. The success of these drugs shows the influence of serotonin and norepinephrine on depression. SSRIs and SNRIs have less side effects than the original MAO inhibitors and tricyclics. Many are also used to treat other disorders. And we'll finally move on to our last drug category, or at least the last drug we're going to look at, lithium, which is used to treat bipolar ailments. And interestingly, it's a naturally occurring salt. Researchers aren't sure exactly why it works, and in fact it's often prescribed as an antidepressant. And it's one of the things that it does do is that it helps control unpredictable mood swings. It seems to be 75% effective, and one of the theories is it may stabilize the level of neurotransmitters in the brain, keeping them from fluctuating, which can be part of what becomes depression. So what about the prevention of disorders? What we've talked about so far is a very typical American way of dealing with any kind of ailment, especially a physical ailment, and that is to treat it after it has already occurred. But in this particular case, since it's very expensive to provide the drugs that people need for drug therapy, and if they happen to go off their medication, then there's a chance that they will relapse and actually have quite a bit of difficulty. So what about the attempt to prevent the disorders? Now, we don't have shots that we can give to inoculate people from mental illness, but there are three types of prevention that are commonly held as potentially successful. The first, primary prevention. Now, this one's a little controversial because this actually relates to family planning and genetic counseling. It's based on genetics, and it really leans heavily on the fact that, as we talked about with many of the disorders, there seems to be a genetic predisposition. Now, again, this is controversial because it gets into moralistic and ethical and religious issues, but it is an interesting idea that attempts to maybe lessen the impact of these predispositions could be supported and done so through family planning. Secondary prevention is the idea of intervention in high-risk groups for some psychological diseases. In other words, people who do have predispositions to things or are in situations that seem to be more apt to create mental illness before they get sick. Physicians and medical providers, and perhaps even the government, because they all seem to be intertwined today, could move in ahead of time and try to do things to try and keep these issues from becoming as prominent. One of the things, of course, could be giving types of therapy, including the cognitive therapies, to people who have yet to show any ailments. In fact, probably something good for everybody to consider. The third type are tertiary, and this tries to help with the transition to the real world after the release from mental institutions or therapy. One of the big problems we have today is that as a culture, we do not spend the money on mental illness that we probably should. And so one of the continuing themes in the treatment of mental illness is once they have been treated, then in a sense they just get dumped back into the public with the hope that they will continue to take care of themselves. We could probably do better in helping with that transition. It's very similar to the idea of just dumping somebody out of prison